Hello, I'm Petros Grivas. I'm a medical oncologist at the Seattle Cancer Care Alliance, University of Washington, and Fred Hutchinson Cancer Research Center. I'm very excited to be at the ASCO GU Symposium in 2020 here in San Francisco with a lot of exciting data. We also had the opportunity to discuss and present for the first time the results of the ATLAS trial, the open-label phase 2 trial of rucaparib, a PARP inhibitor in patients with locally advanced unresectable or metastatic urothelial carcinoma. This study evaluated rucaparib in all comers, regardless of the presence or not of DNA damage response gene mutations, but we also wanted to look at the activity of this compound in the subset of patients that had high genome-wide LOH, loss of heterozygosity, genome-wide, as I mentioned, which is a marker of genomic scarring, genomic instability. So we powered the study to look at all comers, but also in the subset of patients that had high genome-wide loss of heterozygosity. The patient population were patients in the second and third line of therapy, meaning prior platinum-based chemotherapy and or checkpoint inhibitor were allowed, but only 1 or 2 prior lines of therapy. Patients must have had adequate performance status as well as organ function, and they should not have had prior PARP inhibitor. Unfortunately, the results of the study showed that there were no confirmed responses with single-agent rucaparib PARP inhibitor in advanced urothelial cancer in this unselected patient population. And the question remains, would the results have been different if we had selected the patients based on DNA damage response gene mutations or LOH or HRD markers? And I think that's an open question. And the other question that remains is whether the combination of PARP inhibitor with immunotherapy may be still relevant in this disease. I can remind the audience the results of the Biscay phase 1b trial that Dr. Pauls presented at ESMO 2019. This trial, Biscay, had many modules, many arms. One of those, module B, which is a combination of durvalumab plus olaparib and PD-L1 plus PARP inhibitor, showed an overall response rate about 35%, but in a population that was enriched based on homologous recombination deficiency, DNA damage response gene mutation. So you would expect probably a higher response rate compared to durvalumab responses in patients without those mutations. So this was not a randomized trial, so it was hard to discern the signal in terms of durvalumab and olaparib PD-L1 PARP inhibitor combination, but it did not show any significant dramatic signal of activity, which makes me wonder whether the PARP inhibitor plus immunotherapy combination may not be adequate in patients who have platinum refractory disease. That's still, I think, an open question. We'll have to think more in the future how to select our patients for PARP inhibition in this disease. I personally believe that the story of PARP inhibitors in urothelial cancer is not completely done, but again, we have to be smarter in terms of selecting our patients and choosing the right biomarker to inform the patient population that we're going to test this inhibitor. At the same time, in the ATLAS trial, we're going to do a lot of biomarker work, and we did show some data regarding the genomic landscape of metastatic tissues that were biopsied in the ATLAS trial. And the genomic landscape of metastatic disease seems to be comparable with what we had seen before in the historical TCGA data set using primary tissues. So this might tell us that the genomic landscape might not differ significantly between primary and metastatic disease. However, we have to take this data with a grain of salt because these are not paired patients. And we actually, at the University of Washington, we have a very interesting research program that we're actually doing after consent from patients who volunteer, a warm research autopsy program, and we try to compare the genomic landscape between the primary tumors and metastatic tumor sites, and we try to pick up particular differences that might occur in this tumor evolution story. So more data to come in this setting. We published our first manuscript in the JCI Inside from this research autopsy program, and we're going to have more data in the future to try to dissect better the biology of disease and inform innovative clinical trial designs.